to get us going here, I'm going to introduce our host today. Al Lewis is the CEO and co-founder of Quizzify, and many of you obviously know him. And he's regarded as one of the foremost authorities on wellness and population health. And Al has written books about specifically about wellness outcomes analysis. He's very enthusiastic about the company we'll be talking today and the new blood test. Al's written books with Tom Emmerich, who managed benefit at Walmart for more than a decade. They were out talking about centers of excellence programs, better pharmacy benefit management, better medical management. In 2013, those are all now kind of going mainstream, those in next generation plans. So without further ado, here's Al Lewis to lead our discussion today.
Okay, thank you very much, Mark. The first thing is that we did actually put a little trivia question on the title page, and we did get some answers, and what they all have in common is they are all incorrect. X-rays, in fact, did start at a World's Fair at the Buffalo Exposition. There was one inside the exposition when McKinley got shot outside the exposition, and nobody thought to X-ray him. The specialty that started at Coney, yes, we do have an answer. Lee and Kias. It was in fact incubators, which is of course why we asked the question. And actually we got another answer. Now John, yours doesn't count because you actually put it in the Q&A and not the chat box. Okay, so so this is a good reminder to put your questions in the chat, in the Q&A. The chat box is going to be used for polling questions that do not have an A, B, C, D, E answer. So we're going to open this up by telling you why we're so excited about this particular vendor, Sera Prognostics, and how they won a valid vendor award and what it means. Then we're going to introduce the panelists. We're going to have a wide open discussion with lots of chat box. We already have questions into the Q&A, and we will, as I say, we'll be asking you some stuff as well. Oops, let me see what that, okay, here we go. So we did select Sera as a valid vendor of the month. That's just not any ordinary award. Those of you familiar with the healthcare services industry know that there is no shortage of meaningless awards in this industry. Ours is meaningful because we put a third of our own fees at risk in joint accounts for the performance of our partner vendor. Why would we do this? Well, first you have to be validated by the Validation Institute, which is the gold standard for validation in this field. We need to have complete confidence in these folks. There are plenty of vendors who don't put a third of their money at risk for their own performance. And it has to be where there is a synergy for Quizzify, where getting employees educated helps a great deal. Now, those of you who are familiar with my work, my personal blog, know that most of the time I am telling people that most vendors have basically made up their outcomes and are a complete waste of time. And by the way, nobody has ever sued me. I name names and I dare them to sue me. I'm about to show you the opposite, and I'm going to just click through to my personal blog, and you can see we are calling Sera the best vendor ever, and we are saying Quizzify is only number 2. Now that's 2 out of about, I don't know, 5,000 or something, which is still pretty good. But if I'm a CEO of a company, I can only pick one vendor. I pick Sera before I pick Quizzify. So speaking of Sera, we've got some highly qualified folks from Sera on the line who will be participating in this conversation. Rather than go through all their bios, which will be here, I'm going to focus on what we typically do in these conversations, which is we have a guest. Those of you who were on last time know that for surprise bills, know that we had not just outside experts on surprise billing, we actually had a patient who had a surprise bill and was trying to figure out what to do about them. Well, today we have a highly qualified OBGYN, Dr. Barbara Phelps-Sandel. As you can see here, she is founder and CEO of Renaissance Healthcare for Women. She's on the executive committee at Silicon Valley Surgery and was the past chief of the department at a well-known California Peninsula hospital. And Dr. Phelps-Sandel, I understand that you have a passion for prevention that far predates these particular bullet points.
Yes, before I ever even thought of going to medical school, I was trained and worked as a dental hygienist. And the passion I have about that is this is the first profession ever that was based on prevention. The whole meaning of that profession is based on prevention. And I've carried that into my medical work. I also did the fellowship in integrative medicine at the University of Arizona, which is a lifestyle and West meets East type of program to incorporate all types of aspects into lifestyle and healthcare.
So we're going to start out with 2 polling questions to set this up. So this time the poll is going to come up. So don't use the chat box. You'll have a choice of A, B, C, D, or E. Of the dozens of DRGs, which 2 account for the most employer-paid hospital spending? And you can see your choices are birth events, cancer, musculoskeletal, what we call wellness-sensitive medical events, and transplants. So put something into the chat box, and what we typically do while the polls are coming, I just said chat box, I'm sorry. You know, we usually make 1 mistake per webinar, so I think I just got that one out of the way. No, use the polling feature for this. And then we have other questions coming in, which is, we have actually quite a number of them. And probably the ones that are coming in are a little anticipatory. So I think we'll just wait for more appropriate time. And Mark, do we have an answer on this one? Yes, birth events do, and musculoskeletal second. So I don't know if you can see this on your screen or whether I can just see it on mine. But 7 out of 8 people, I don't mean only 8 people, I mean percent, did go with birth events, and almost half went with musculoskeletal. Those are indeed number 1 and 2 as DRGs. So I'm going to just close this out on my screen and move on to the next. We have 1 more polling question, which is now, those were DRGs. Now we're going to get very specific. Of the thousands of specific condition categories, which of these conditions is not in the top 25 of employer-paid hospital spending? And your choices are normal delivery, extreme prematurity, diabetes prematurity, other prematurity, and cesarean sections. So once again, I think we'll do this one right away, because the questions that are coming in are going to be addressed a little bit later anyway in the show. So we'll just go right to an answer, even if we don't have all the guesses in yet. Okay, so the full-term normal delivery won, but in fact, full-term normal delivery is, as you'll see, in the top 25. What many employers don't quite grasp is that if you have 60 hospitalizations per 1,000, which you probably do, fully 20 of those are going to be some kind of birth event, including normal ones. And this takes us to the next slide, which is a list of the top 25 hospital inpatient expenditures in aggregate for all employer-paid hospitals as a whole. The data is a little bit old. It's like 2015, because I don't collect it anymore for some reason. But if you go down these top 25, all you see, for the most part, I'm exaggerating a little, they're largely musculoskeletal and especially birth events. So musculoskeletal, birth. ECMO is in yellow because it can be neonate, or it can be regular adult. Birth, musculoskeletal, birth. You're seeing a little bit of a trend there. So, and yet, think of how much of your wellness budget you are spending on these 2 categories, particularly birth, versus things like diabetes that don't even show up on the list of things that are preventable. So I am now going to turn this over to Jamie, who will tell you a little bit about preterm births and what we're going to do about them.
Thanks, Sal. Yeah, so preterm birth is defined as birth of a newborn prior to 37 weeks gestation. And surprisingly, in the US, that occurs 1 out of every 10 babies born. And unfortunately, preterm birth is still the leading cause of newborn mortality and morbidity. and is often associated with long-term health impacts for that child. Now, obviously, these statistics don't touch on some other important considerations, which is the impact to the parents of a premature baby, to include, both mental health considerations as well as workforce issues like absenteeism and presenteeism.
So we're going to do another polling question. So you've just heard about preemies, and that 1 out of 10 number, by the way, Jamie, I don't believe has come down in the 25 years I've been in this field.
That's correct, Al.
Of the 1,000 or more categories of condition generating claims on stop-loss insurance, how many account for more claims than preemies? And this time, swarm the chat box here. And then I will have, I do have a couple of questions here that are probably relevant now. So this sounds like a great thing. And the question is, does insurance pay for it?
Yeah, I mean, I think that, most costs associated with a preterm birth are covered in some manner with health insurance, depending on the overall deductible, et cetera. But it is at an extreme cost, and it's really plan dependent on what exactly is covered.
So, and we will just be discussing that in more detail. We have some answers here, Mark, but it looks like the closest is probably David Hester. Oh no, actually no.
It looks like Keith McNeil at 3
yes.
is probably the closest answer.
Yes. So Keith McNeil is actually also notable for being one of 3 people in the last 13 years to find a mistake in my work. So congratulations to Keith for this one as well. So let's go to the actual stop loss. And this is one insurer. One stop loss insurer who had a nice graph. So I picked that. But you can see that Keith said 3. There are actually 4, at least for this particular insurer, that are higher than premature birth. Now, one of the things to notice about these 4 that are higher is they're kind of a 0-1 thing. You either have them, i.e. you've got cancer, leukemia, or neoplasm, not cancer, another non-neoplastic cancer, end-stage renal or congenital anomaly, or you don't. Whereas for preemies, my suspicion, and folks at Sera, if you have a different view, let me know, is that for every preemie who triggers the stop loss, there are probably 2, 3, or 4 to 5, maybe depending on where your trigger point is, that are expensive but don't trigger the stop loss.
That's absolutely accurate.
Okay. So Keith can't correct me on that one too. Okay, so I will turn it over to you folks to talk a little bit about more about the economics.
So what is driving the cost? I think most of your viewers are probably aware of the fact that typically when a baby is born prior to 37 weeks, that baby stay in the hospital is often associated with a stay at the neonatal intensive care unit, or NICU. And NICU claims are some of the highest claims currently being billed to payers, right? And at a granular level, you're looking at a preterm birth costing upwards of 20 times more than a term birth. It's obviously a great contributor to total newborn costs. And at an aggregate, we're looking at about $32 billion of spend annually across both commercial and government payers.
So we did not get a question, and I thought Keith might jump in with this question about how can possibly the cost of a full-term baby be $2,400, and I can answer that one, which is that about half of the preemies are Medicaid babies, and I don't know how many of you have ever seen a bill from Medicaid from a hospital for anything, but it has shockingly few digits in it. The thing to focus on is the multiple between full term and preterm. Okay, so we have another question. Now we're gonna segue into how you predict these things. And the question is, what % of pregnancies that deliver preterm can be predicted today through traditional screening methods. And once again, use the swarm the chat box here to answer your question. I'm actually getting pretty good at calling up the chat box. So we actually have we have some pretty close numbers right now. So actually, people are shockingly good at this. We've got several people at 20. A bunch of people at 20. So heads up, congratulations to Elizabeth Green, Keith again, and now let's not always see the same hands. And Bobby Dahl, and honorable mention to Carolyn Grant, who is also pretty close. And actually Brenda Nixon. Brenda Nixon comes in within 2. So I will once again turn this over to Sarah.
Yeah, actually, Dr. Phelps-Sandel.
All right, well, we don't have good predictors is the bottom line. What we use is cervical length, which is done by ultrasound somewhere around 18 to 20 weeks in a pregnancy, and a previous history of preterm labor. For anybody that it's their first time pregnancy, you don't have that information. They are a complete unknown. So we're not very good at it, and about 17% of the time we're right. Not great. 1 in 10 babies right now are being born prematurely. Many of those don't have to be. We've got to change those odds.
And tell us about the technology you used to change them.
Yeah, absolutely. You know, identifying the right patient is the challenge that really drives our mission at Sera. So through a 4-year R&D process, we developed the PreTRM test, which is the only validated commercially available blood test for providing individual prediction of premature birth risk. The test detects the presence of 2 protein biomarkers, IBP4, which is associated with placental function, and SHBG, which is associated with inflammation. And both placental, let's say, dysfunction and inflammation are significant contributors to the overall etiology of preterm birth. Preterm has been clinically validated in 2 large published clinical trials of over 10,000 women. And we have a strong pipeline of evidence development for additional publications this year, which we'll touch on a little bit later.
And just to put this in perspective, you haven't just been doing this for 4 years. There was some trial and error involved, right? I mean,
correct.
Yeah.
Correct. That is. We've been at it for much more than 4 years.
Well, you know what Thomas Edison said, it's genius is 98% inspiration, 2% inspiration, 98% perspiration. And I think you proved that.
Thank you.
So now talk about how you'd actually apply this.
Yeah, so preterm is suitable for the majority of all pregnancies. So specifically, we're indicated for singleton pregnancies with no identifiable risk factors. And the test is administered through a simple blood draw, which is done between 19 weeks and 1 day and 20 weeks and 6 days, in which the results are sent to the patient's provider within 7 days or so.
And why does it have to be so precise?
So the clinical validation that we did, the research that we did on the test showed that the detection of the biomarkers are most relevant to risk between those windows of gestation.
So if you miss it by a little, it might still be somewhat predictive, but you just not the numbers that you're claiming.
Yeah, so we can only speak to what we're indicated for, which is that 19 weeks and 20 weeks, 6 days.
Yes, and I might draw a very bright line between Sera and typical wellness vendors. They can basically say whatever they want because they're not licensed by or regulated by anybody.
Right.
And if you just wanted to talk briefly about why you only do this on singletons and what a singleton is, just
sure. Yeah, thanks for the question. So singleton pregnancies is a single baby in utero. If you are pregnant with a multiple gestation, and sure, Dr. Phelps-Sandel, you can weigh in here as well. That is already considered high risk. So you have a 50% risk of delivering preterm if you're pregnant with any sort of high order multiple gestation.
So you saw the number of 17%, which is what traditional methods, and Dr. Phelps-Sandel, I think traditional methods have been essentially in place since almost the invention of ultrasound. I mean, we're looking at, well, not that long, but probably hasn't changed in 20 or 30 years, right?
Yeah, that's correct. I mean, things that we do to follow these pregnancies, or we use progesterone that can be injected, which is a weekly thing. We can use vaginal suppositories, which is a nightly thing. We can check cervical lengths using ultrasound and also vaginal exams. More frequent appointments and monitoring go on with this. We can intervene with hospitalization when we determine it's necessary. We also educate patients on signs and symptoms of preterm labor. This requires a lot of vigilance on everybody's part. It's the bottom line.
So you have a protocol. It's just a question of really, number one, applying it to the right people, and number two, having the folks that it apply to believe that it's worth their while to do it.
Exactly. You need to have a feel for when you need to escalate things and really intervene with what's going on.
Okay, so as you look at that 17% number, go to the chat box and swarm it again. What percent of singleton pregnancies, as compared to the 17, that deliver preterm can be predicted with preterm plus the traditional methods? And jump on the chat box, and I think I'm actually getting pretty good at opening this. Oh, yeah. So, you folks have already made it. Oh my goodness. Keith, you're killing me here. You're making everybody else look bad. Keith, there are a lot of answers and they're all, quite high, but Keith hit it on the nose with 92%. So I will once again turn it over to Sarah.
Yeah, absolutely. And this is where the preterm test can really complement these current methods for screening. When preterm is added to the methods that Dr. Phelps-Sandel mentioned, you can capture 4 to 5 times as many women, or up to 92% of all women who are at risk for preterm birth, which is really making meaningful impact in that 50% or so of women right now that are not being identified that go on to deliver early.
Oops. So this would be a great time to just kind of describe. You already talked a little bit about the protocol. Maybe just talk a little more and talk about a case study or two.
Yeah, sure. I mean, I mentioned things that a doctor does to help intervene with this pregnancy along with the patient, but to kind of define this a little bit more in terms of a patient's buy-in to all of this. We spend a lot of time educating patients. We have to talk with them about their nutrition. That's important for any pregnancy, but especially for one that's at higher risk. Exercise. Incorporating prenatal yoga. There are good studies that show you actually can reduce the risk for preterm labor with doing prenatal yoga throughout pregnancy. Oral hygiene is incredibly important to reduce the risk of inflammation. Vitamin D, prenatal vitamins with omega-3s. Good sleep is a really important thing too. So this is kind of like a prenatal lifestyle format that we ask patients to follow. Hopefully it'll be a lifetime format for many of these items in here, but these are important things. And I kind of think it goes without saying with any pregnancy, no tobacco, no alcohol, no street drugs. Marijuana is not a good idea for relaxation. And then to go on and talk about a particular case, this was a 37-year-old woman who on her first baby, preterm test came back and showed that her risk was 2.2 times the risk of the general population for having a preterm baby. So instead of being like between 8 and 10%, her risk was 16. And obviously, since she had delayed childbearing, this was really an important thing to her. We started her on our routine of she's going to be using vaginal suppositories starting from that day on. We're going to be seeing her more frequently. We're going to be doing more ultrasounds to measure the cervix, but also to measure the baby's growth. We're going to do more frequent vaginal exams. It's labor intensive on our part, on her part too. We do fetal monitoring once we get to at least 32 weeks to follow baby's heartbeat, but also to look for contractions. And then on her side, we spend a lot of time educating her about the signs and symptoms of preterm labor. You know, that little low backache may be something significant. Don't ignore it. Other things along the way. To make a long story short, she followed everything to the hilt. She stopped using her vaginal suppositories at 37 weeks. That baby delivered at 37 weeks in 2 days. It weighed 7 pounds, 2 ounces, and she went home from the hospital with a baby in her arms.
That's great, great news. And as one who has had family experience with preemie, I know what a humongous difference that makes. But they don't all turn out that way, right?
That's absolutely correct. This baby, had it delivered a few days earlier, would have been considered a late preterm baby and may not have done as well.
But I think you had another example maybe that didn't do so well.
It did not, yes. Do you want me to talk about that one now?
Sure.
Okay. This is a 44-year-old. She was pregnant for the 3rd time. She had 2 early pregnancy losses, so her anxiety was incredibly high. Her preterm test result came back at 8.2 times the risk for a preterm birth. That was more than 60% chances. And so to me, it was inevitable. It was going to happen. But this information was so empowering. We basically had to enhance our management for the very best outcome possible. She was already on low dose aspirin. We started her on progesterone suppositories. We were doing even more frequent cervical checks on her. Ultrasounds for fetal growth, and lots of patient education. We had frequent contact with this patient, not just with me, but also with my staff, because that was important. She needed that support. At 27 weeks, we had an ultrasound that showed fetal growth was estimated at 2 pounds, 4 ounces, and we were thrilled about that. 2 days later, patient called complaining of some low backache, lower abdominal pain, and increased urinary frequency. So we had her come in, we did some monitoring, we checked her cervix, which was long and closed. We scheduled her on antibiotics, or started her on antibiotics, because we were working with the diagnosis of a bladder infection at this point. All of our precautions were reviewed. We sent her home and told her to stay in touch with us. Well, she called back later that evening saying that she was in a tremendous amount of pain. We sent her to labor and delivery, and she was evaluated there. She had a closed cervix. She was contracting. We started her on a medication called magnesium sulfate, which is given IV. It's miserable, but it stops contractions and also has the added benefit of adding neuroprotection to a baby's brain. And with this medication having been on board at some point in time in the pregnancy, there's a lower risk of a preterm baby having cerebral hemorrhages. We also treated her with steroids. After 3 days, things had been settled down for 2 days, so we monitored for a longer period of time. We checked her cervix, it was closed. She was ready to go home. She had had enough of the hospital, and everything was so stable, we sent her home. 8 hours after discharge, she called me and said she was in excruciating pain and she was in distress. Sent her back to the hospital, her cervix was dilated, and she delivered a baby shortly thereafter. The baby went straight to the NICU and was there for 3 months. Mom's course was rocky. Her anxiety was even higher. She was very emotional. She was exhausted. She developed depression. The baby did incredibly well, was never on a ventilator, was on oxygen, but never on a ventilator. Now, at the same time, this is a baby that could not be fed by the mom. This was a baby that couldn't be held. And if you've never seen a premature baby, they are not just a smaller version of a term baby. These babies to me look like little birds. They should grow feathers. They have no body fat, so they have very transparent skin. You can see their blood vessels. Sometimes you can even see the motion of their heart beating. So it really doesn't look like a human baby. With all the effort that went into this, though, this baby went home at 3 months, doing very, very well. There are ups and downs along the way, but the difference is that she was treated, and at 27 weeks, 5 days, with the treatment that we gave her, this baby had a very different outcome than if we didn't know this mom's risk. She delivered at the same time and didn't have those protective medications on board.
So yes, my sister had the magnesium, and she was absolutely miserable. But on the other hand, she almost went to term. Now, one question that's come in is that ACOG, for uninitiated, I think that's the American something of obstetricians and gynecologists, right? The
American Congress of Obstetrics.
okay. I would not have. I would have said college, but are not recommending biomarker screen. Is that because they don't believe in it, or they just haven't? Sometimes, as Marty McCary has written in Health Affairs, sometimes a breakthrough takes place long before it gets accepted by the profession.
Yeah, it's a conservative group, to say the least, which is probably a good thing. We've been burned before by jumping on board things too soon and end up retracting what we have to say about it. So they are very careful.
And while we're on the subject, we're now getting, in addition to the chat box having been flooded, a lot more Q&A. And if we don't get to your Q&A now, we will answer it online. So we've talked about how good this is as a predictor of potential preterm birth. Are there people who, about what % of people who test normal or negative on preterm end up with premature birth?
The vast majority do not. There's a small percentage, but as long as the patient and the doc are on board with the program, they may still deliver preterm, but there's a big difference between delivering, say, at 24 weeks or prolonging that pregnancy to 28 or 30 weeks. That's big success. But I don't have an exact percentage for you. Jamie, do you?
I'll take that as a follow-up to the audience question for sure.
Okay.
So that's a great answer, and it leads right into the next slide. But this is a different question, I think, which is moms who go in for this test, who test that they are in the normal non-high risk range. Have you tracked what percentage of people who test negative, meaning, not at risk, then go ahead and deliver early?
Sure. So I know that we have that available in our data. I don't have it right in front of me, so I'll follow up with Al with the audience once I get that data.
Okay, and one of the questions is, what's miserable magnesium sulfate? I will answer that question myself afterwards, but just imagine yourself in complete slow motion, unable to essentially move anything without a lot of effort. So as you can see from that slide over there, exactly what Dr. Phelps-Sandel said is taking place on a cost basis as well as a health basis. Is there anything that you folks at Sera would like to add to this slide? I feel like we kind of talked about it a bit.
Absolutely. I'll just complement what's already been discussed. I think Dr. Phelps-Sandel, gave a real world example of the impact of delaying as much as possible gestational age of birth. This data and the slide that you see was from real world national payers, real world claims data, of tracking birth claims for births 12 months from birth. And it just shows how significant even a 2-week, a 1-day delay can actually make in outcomes and costs. It's considerable. So
you actually, unlike, as I say, most vendors, you actually have real honest to goodness studies. Would you like to share them?
Sure. This slide really is speaking to the fact that we have several studies that have been completed and are underway, where we really are defining or helping to define the value of not only identifying the higher risk pregnancies, but when you combine that with proactive interventions, what's the impact on outcomes, not just clinical outcomes, but also more health economic cost outcomes. Clinical outcomes, we look at a measure on neonatal health across the spectrum, and that in turn drives and has been shown to drive reduction. Healthier the neonate and the longer the gestational age of birth, the lower the neonatal length of stay from birth, which results in significant cost savings versus current standard of care.
We have a couple of questions come in. Once again, if we don't get to you now, we'll get to you later, that are relevant to the last conversation. So the question is, wouldn't that person who was age 44 with 2 previous losses already have been considered high risk without the preterm test?
Her age certainly would put her at higher risk. And she was a first-time mom, even though it was a 3rd pregnancy, she was still a first-time mom.
So it's you had mentioned before, maybe it was during our rehearsal, that it's not just about the predictive value of the test. It's about the commitment that the patient has to make to the protocol, and perhaps the test increases that commitment.
Yeah, what I had mentioned was just telling her you're older, it's your first baby, that puts you at higher risk. That's kind of vague to a patient. They are who they are. But when I've got this test result and it had this giant in bold print, 8.2 times the risk, that hit home. That's when she really jumped on board. And it was at a time in the pregnancy where she had to be engaged. We got her through the first trimester, which she was thrilled about since she lost the other 2 so early on. But now she was probably thinking, I'm kind of out of the woods now, and not the case. And that test result drove it home.
Yes, and I think and we had talked about this in our rehearsal, and that, half of it is not just the prediction. Oh, I sound like Yogi Berra. half is the prediction, but the other half is the confidence in the prediction and the impact on the patient's point of view for the commitment that they have to make.
That's right. That's absolutely right.
So we have a whole bunch more questions coming in, but I want to make sure we get to the actual result from the study here. So Darren?
Thanks, Al. So one of the studies that we have completed and in the process of publishing, there is an abstract available. That was a prospective randomized control trial that showed versus standard care, a preterm strategy reduced from a median stay standpoint, total neonatal hospital days after birth by almost 83%. And this is statistically significant and speaks to at least partially the impact of, again, the preterm strategy on reducing the length of stay in the hospital.
Now this includes the people who delivered at term, so they'd have a 0. So you count everybody who got the test.
Absolutely,
Okay.
all births.
All right. And like I say, you got 2.5 pages of footnotes, but just tell us a little bit about this study as well.
Sure. This study was a retrospective analysis of 2 of our large prospective clinical studies, which Jamie mentioned previously. And it looked at the comparative effectiveness of current screening and current standard care methodologies for identifying and treating preterm birth risk versus a preterm strategy. And what we found, again, completely statistically significant in all 3 of the areas that I mentioned, the impact on neonatal health after birth, the impact on length of stay for a neonate, and then the associated costs were significantly reduced or improved. This study manuscript is being submitted to a peer-reviewed journal, and we are happy to talk further with any interested party under CDA to delve into the results further.
Now, before I let you go off this slide, there are now about 2,000 peer-reviewed journals, of which about 1,970 are done on a for-profit basis, where where vendors, and I won't mention any names, but they might rhyme with Livongo, will simply purchase some space and publish an article and get some kind of very light peer review. These journals have figured out that you can make a lot more money charging the vendor than charging for subscriptions. Is this one of these for-profit journals, or is this legitimate non-for-profit journal?
Legitimate not-for-profit journal. We really take our evidence development extremely seriously, and will only publish in journals that are extremely well respected in the various clinical and other stakeholders. So not-for-profit.
Yes, and we have a study coming out today, not a study, a series of white papers coming out today in the Validation Institute, where we are talking about how to validate vendors, and certain things we say, or there's certain red flag words that when you see them, you should ask another probing question like I just did. And one of them is peer review. Peer review is the magic of the this year and last year, and not all peer review is alike by a long shot. So we have some questions, and while we're doing that, let's swarm the chat box. These are actually some of the questions. What is the cost of the test? And it says here we'll take the first guess within 20%. So swarm the chat box. And meanwhile, we have a few questions from the audience here. One is, how can this solution be integrated and paid by self-insured employers right now?
Currently, we are working with carriers, health plans. We have a national payer that is paying for our test, and we continue to have those discussions and make those agreements. And we are also starting to talk to self-insured employers that are interested in implementing the preterm test as part of maternity benefits.
So we're getting and those of you who are Quizzify customers, we can certainly help with that. We're getting a lot of answers, and to be honest, I actually thought people were going to be over guessing, but there's a lot of under guessing. I think you have no idea what goes into. I mean, you've been working at this for what since 2008, including all your false starts, right?
Correct.
Yeah, so I am seeing numbers, and once again, I think Keith McNeil wins again. Now, Keith, you haven't seen this presentation before, have you? He came in a little bit low still at 500, but the answer is, Sarah?
Yep. So the cost of the preterm test is $745. And, what we are looking to do in an effort to partner with interested parties is offering a shared risk pricing in which we would look for 53% of the price up front. And when metrics of NICU length of stay reduction are achieved during the course of the contract, we would look to collect the balance as a result.
So just to elaborate on that a little bit, this is in percentage because my suspicion is even though people were guessing low, that the price may go up after the quote unquote early adopters. Of the 53% that is at risk, I'm sorry, there's not at risk, for Quizzify accounts, we are basically taking half of that risk onto ourselves. Because we completely believe in this, and if you think 745 is a lot of money, think what you're spending in the NICU, and remember this is to guarantee to easily pay for itself quite a bit. So we have a whole bunch of questions that have come in, and we actually have a little bit more time than we usually have, so we may be able to get. I'm putting on my glasses here. There are companies that offer family planning and fertility benefits. How can this be integrated into that?
Yeah, it's a great question. And I think that that's something that we've looked to integrate, in terms of employee education and education from a preconception information about benefits. So, I think we are open to, talking with some of these fertility benefits companies to understand, their touch points with the employees or with the covered lives, and providing extra information regarding the preterm test as a result.
When I'm doing preconceptual counseling with a couple, I give them information and talk with them at that time a little bit about the preterm test too.
And just to make sure there's complete clarity here, I mean, you are doing a nice high ROI on NICU days, but there are other costs involved in possibly perinatal stays, in the protocol itself for high-risk moms. But there are also other benefits in the post-birth health status of what would have been a much more fragile baby, correct?
Correct. And Darren, maybe you can mention just at a high level some of our modeling resources for folks.
Yeah, absolutely. And I was gonna bring this up. I did see a question also related to it. So there was a national payer who developed a health economic model using their own claims data for over 40,000 neonates enrolled in their commercial plan, 12 months continuously after birth. So they're looking at 1 year of cost post-birth. And they developed a model which shows, and there's customizable inputs, right? That, you know, what percentage of women took the test, what percentage of women tested positive or higher risk and complied with treatment, the cost of the test, the cost of the interventions, number of pregnancies, et cetera. So it's a customizable model. And the dominant finding in almost any scenario that was put into it, and there is a manuscript which has been submitted for publication in support of this model, again, using real world data, showed that there's significant cost savings through reduction in neonatal days in the hospital, primarily with a preterm strategy versus standard care, and that includes cost of the test and cost of interventions.
Cost of the test, cost of interventions, and relative cost of that first year, or not?
Correct, yes.
Okay. So just before we do a few more questions, just a little correction, and Mark has texted me on this, and I don't like to wear my glasses on these things, so I look even more ridiculous with my glasses than I do otherwise. We need to credit oops, what was her name? Sena. I gotta put my glasses on.
I think it's Sena, H-A-E-R-A.
Who guessed $800, which is actually very, very close. So we have a few other questions as well. You can probably see them in the chat box if you'd like to just pick one out to answer, or I can prompt you. I don't mean the chat box.
Well, I thought there was a good one for Dr. Phelps in terms of, you mentioned the protocol once you know someone's high risk, but you can't be everywhere. Are the protocols you're using to treat high risk available to all other OBGYNs?
Oh, yes, absolutely. Mm-hmm.
So I mean, my understanding would be that the protocol has been around for years. The question is just who you put on the protocol, right?
Right. You don't want to over-treat. But it is valuable. It's not a big protocol, obviously. We don't have a whole lot of tools, and we haven't had a big impact on preterm labor because of that. But we're getting better, and if we know who is at risk, we can at least employ what we have until we've got more to add to it.
So you had not mentioned the names of any insurance companies, and you're not required to, but are there insurance companies that are now reimbursing this? Do you need to make it part of your plan design? That's the question, basically.
Yeah, so we do have a commercial agreement with one major national health plan for coverage of the test. But essentially what we would be looking to do with the self-insured employer group is to provide it as a covered benefit within their maternity benefits umbrella. And
so at what, actually, I think we already answered this. And I was going to say, at what gestational age is can the test be drawn? How is actually, I think a couple of these questions have already been answered. Oh, how are the results shared with the treating obstetrician? And you said it would be 7 days. Is that what you're aiming for in the future? Is that what it is now?
Yeah, so that's what our current turnaround time is, and our results are either they have the opportunity to receive them either faxed back to the physician, or the results are accessible also through an online portal that we've set up for ease of ordering. And our goal is to continuously refine our testing process back at our laboratory to reduce the turnaround time even more significantly.
Because basically the sooner you know, the more actionable it is. Does the test distinguish between spontaneous preterm birth versus iatrogenic, i.e. non-spontaneous preterm birth? That one would, of course, be Dr. Phelps-Sandel.
I'm not spontaneous preterm birth versus not.
Iatrogenic, which I thought meant hospital-acquired infection, but maybe I don't know what it means.
Yeah, the preterm test right now is for spontaneous preterm birth. We continue to do studies looking at all preterm birth, and there is a publication that is out. There are two publications on our clinical validation. One is called paper, one is called treetop, that we can share with anyone interested offline. And that's something we continue to do a lot of work on for future types of broader indications. But right now the test is for determining an individual woman's risk for spontaneous preterm birth.
Is this test done on essentially any woman who is identified as pregnant by, self-presenting at the employer, or the employer says that this is available, or is there a pre-screening to actually get the test?
So if it is a benefit that a employer offers, there would be a whole educational component to ensuring that she understands how, where, when to get the preterm test. So we would be actively involved in that process with the employer. And then we have also staff that would support the patient and help her with all the arrangements to have her blood draw completed, and also support her clinician and or the practice that she's working with.
And I would add, Al, that our test is generally indicated, as Jamie spoke to previously, for about 88% of all pregnancies. If you have a risk, if you've had a prior preterm birth or a shortened cervix, you're already considered at high risk, as an example. So part of the answer is, I think, 88% of.
So 88 plus the 12 were already at high risk. So essentially 100% of people, one way or the other, will be measured for risk.
Al, there's another question here. We talked about one large national carrier insuring for this. Can anything else be offered about large self-insured employers integrating this solution with their family planning / fertility benefits? Can anything else be said about companies that are doing this that are self-insured?
We're in the process of rolling that out. We're having lots of discussions with very small, mid-sized, and larger companies, working through that rollout as we speak. We're just embarked upon that, and have dedicated staff focused on those conversations right now. And our interest is to select very specific deployments with early adopters and innovators that want to make a meaningful difference to their employee base. And the same thing with insurers, both on the national level as well as regional level. And we're also working very closely with specific integrated delivery networks to initiate rollout.
And of course, you have to detail the obstetricians in a given city or market where you are.
Correct.
Okay, so I think we've actually used up all the relatively easily answered questions in the Q&A, and we do have a little time remaining, which is unusual, but what it speaks to is I remember when I applied to business school, there was a saying in the admissions office that the thicker the file, the thicker the student. And likewise, I think if you can tell your story with Q&A in 53 minutes instead of 60, it just means it's a really good story. So, unless anybody has anything else to add, I think we can start drawing this to a close.
Sounds good. I'll just add one comment because I think there are some very specific clinical medical questions that are left unanswered. We don't have representation from Sera on the clinical and medical side. We will take every one of those questions, provide responses, and submit those.
Yes, and that's and they will come in an Excel format, probably within about, we always say 7 days. We usually beat it, but we're going to say 7 days. Okay, well, so thank you very much to all of our staff, and thank you very much to our attendees, most of whom stayed to the end. And we will be in touch with, we will be sending you the presentation and the recording within about 48 hours. And we will be sending the answers to the questions within about 7 days. And we'll also send you a link to the story about how the neonatal field got started at Coney Island. And that by itself is worth opening our follow-up email for. Sera, thanks once again. And
thanks so much, Al.
Thank you.
We will be signing off.
Thank you so much. Have a great day.
Take care, everyone.
Thank
Bye,
you.
everybody.
Bye.
Thank you. Bye now.